Buen día, vamos a esperar unos 2 minutos para ver si se conecta Ricardo y Poncho. Bueno, vamos a comenzar, vamos a continuar con la- los temas del Congreso Europeo, nada más el día de hoy y ya lo dejamos ahí por la paz.
Hello and welcome. My name is Gerhard Hindricks from the Heart Center Leipzig in Leipzig, Germany, and I welcome you to the ESC Digital Experience. The title of my presentation is How to Assess Risk of Sudden Cardiac Death. These are my disclosures. I have some relation to public funding, but no industry relations at all. I would like to start off with one of the most beautiful slides from cardiovascular medicine over the last decade that shows the decrease of sudden cardiac death over time in the last 20 years. And it's because of you, it's because of the cardiologists, it's because of the general practitioner, the quality of care in the field of cardiovascular medicine that led to the significant decline in total mortality in patients with reduced ejection fraction structural heart disease, and also with, to reduce sudden cardiac death. Is the problem of sudden cardiac death solved? No. The prevalence of people and patients at risk for sudden cardiac death continues to increase. So we have to continue to work to prevent this deleterious events of fast ventricular tachycardia, ventricular fibrillation, which is the main cause of sudden cardiac death. So sudden cardiac death continues to be a leading cause of death in Europe and in the westernized world. We need to stress the question, how can we improve the identification of people and patients that are at high risk for sudden cardiac death to protect better and prevent sudden cardiac death, both after myocardial infarction and also in the patient population with so-called non-ischemic cardiomyopathies. Sudden cardiac death is really a complex scenario. It's beyond the scope of this presentation to go into details. But the risk of sudden cardiac death is defined by the interplay of various autonomic, perfusion, electrolyte, and electrophysiologic factors that contribute in a dynamic function in order to define the risk of sudden cardiac death. We have developed over the last 30 years various diagnostic methods in order to get control of these risk factors and to improve risk stratification. However, as you can see on that slide, most of the approaches with electrical diagnostics to identify and autonomic diagnostics to identify patients at risk of sudden cardiac death unfortunately failed. So none of these strategies proved effective in predicting sudden cardiac death to achieve guideline relevance. And in one of the keystone papers from the American Heart Association, it was stated that it may not be worth the effort to invest more into risk stratification for sudden cardiac death. I don't think that's true. Never give up. We need to intensify our efforts to better understand sudden cardiac death and to prevent it more effectively by improved risk stratification. These are the current guidelines from 2015 that show that the indications for primary prevention ICD implantation for the protection of sudden cardiac death is simply based on left ventricular ejection fraction. Less than 35% qualifies for an ICD, more than 35% does not qualify for an ICD. Is left ventricular ejection fraction enough? No. We need to think broader. We need to think new lines. And I would like to share with you some ideas that have been recently published showing that we can significantly improve risk prediction in sudden cardiac death. I would like to start off with this marvelous study published in European Journal of Heart Failure recently, as it shows the usability of a risk score for risk prediction of arrhythmic events and sudden cardiac death after myocardial infarction. These data have been taken from the Capricorn and Violent trials, patients at high risk for sudden cardiac death post-myocardial infarction, and various patient characteristics have been identified and have been combined to a score quite comparable to the CHADS-VASc score to predict stroke, and CHADS-VASc works well in stroke. So there is good evidence, at least, to evaluate whether a risk score better predicts risk for sudden cardiac death after myocardial infarction as compared to a single factor. And as you can see on the lower left of the slide, there is, with the increasing score rates, an increase in calculated and observed risks for sudden cardiac death. So this is one way that I consider particularly promising to better protect from sudden cardiac death. We will follow these lines in the hugest project for risk stratification and risk protection that has ever been done on the planet, which is guided by the European Society of Cardiology, the PROFIT project. Risk stratification and risk evaluation in clinical trials to better identify people and patients that would benefit from defibrillator therapy. In current guidelines, we have the following problem. In the patient population with ejection fraction of less than 35%, there is potentially over-treatment, while in the population with ejection fraction of more than 35%, there's under-treatment for sure, because these patients are unprotected for primary prevention at all. With the PROFIT project, we would like to go to a personalized approach to better protect regardless of left ventricular ejection fractions. We will perform an analysis which is currently ongoing as the first step of more than 1 million individual post-myocardial infarction patient data, develop a risk score, and then go into 2 different clinical trials, 2,000 patients each, PROFIT reduce and PROFIT preserve, and evaluate based on the new risk stratification score the effects of defibrillator therapy when guided by risk stratification score. Let's take a quick look to non-ischemic cardiomyopathies, where the dilemma is even more pronounced as compared to post-myocardial infarction patients. Why is this the case? Because non-ischemic cardiomyopathies is not a well-defined entity of a state of disease. It's a box where various diseases, various substrate, and various risks for sudden cardiac death are combined. So we need to better understand the risk stratification in non-ischemic cardiomyopathies, take a more individualized, personalized, substrate-based look to risk stratification for sudden cardiac death. The risk is significantly different in various states of disease. On this slide, you see that the variation of risk for sudden cardiac death in non-ischemic cardiomyopathy trials and studies varies between 0% and 20%. And this is mainly due to the patients included into these trials. I would like to share with you one idea for the non-ischemics that may significantly improve risk stratification. That is the identification of fibrosis, late gadolinium enhanced investigations with the CMR. And there is good data that the presence and absence, even today these data are there, may be very helpful to identify patients at risk for sudden cardiac death better than ejection fraction, where the localization and the extension of these LGE areas may add additional value for improved risk stratification is currently evaluated in clinical trials. I am very positive that we will learn a lot and that we can take a lot from these imaging technologies. The potential of the imaging technologies has been shown for patients with non-ischemic cardiomyopathy and ischemic cardiomyopathy. In this analysis, the risk for an tachyarrhythmic event stratified by presence and absence of left gadolinium enhancement fibrosis is shown. And as you can see, risk prediction can be improved if these CMR data are included in our strategies. My second last slide should point out that not only for post-myocardial infarction patients, but also for non-ischemic cardiomyopathy patients, scores are currently evaluated to improve risk prediction. This is the estimate score that has been recently published. It's the same principle. You take variables and you combine them to a score, and these scores should have the potential to improve risk prediction. Needless to say, most of the scores that have been presented to the community are based on retrospective analysis. They are of huge value. That's beyond doubt. But the value of these scores need to be evaluated in large-scale clinical trials in order to prove the efficacy of these risk stratifiers in order to prevent sudden cardiac death and to reduce total mortality, as we do it in the PROPHET project. I would like to summarize risk stratification for sudden cardiac death. Where do we stand? Risk stratification for sudden cardiac death needs to be fundamentally redefined based on the reevaluation of existing data, both for post-myocardial infarction and non-ischemic cardiomyopathy patients. A better substrate and pathophysiology-based understanding is necessary for a more appropriate and precise risk stratification, particularly for patients with non-ischemic cardiomyopathy. Left ventricular ejection fraction is not enough. Left ventricular ejection fraction-based risk stratification is likely to result in overtreatment in a significant portion of patients with heart failure and reduced ejection fraction. On the other hand, currently a huge number of patients is completely unprotected, those with an ejection fraction of more than 35%. And we need to take care for this population as well. So large clinical trials, strong efforts are necessary, such as PROPHET, to improve risk stratification and improve the quality of care for people and patients at high risk for sudden cardiac death. Thank you very much for your attention. I hope you enjoyed the digital ESC experience, and I'm happy to take your questions.
Yo creo que es un tema bastante relevante, ¿no? Residentes, cómo calcular el riesgo de muerte súbita en cardiopatía isquémica. Entonces, creo que no lo tenemos mucho sí en el radar, a menos que tenemos los scores de riesgo de mortalidad intrahospitalaria, etcétera, ¿no? Entonces, Miguel Galicia, te encargo que hagas una búsqueda del score de riesgo de mortalidad de muerte súbita en quienes nos guiarían para poner un desfibrilador automático implantable, un desfibrilador automático, en pacientes posinfarto, ¿no? Con cardiopatía isquémica o síndrome isquémicos coronarios crónicos que veamos en una, ya después del síndrome isquémico coronario agudo, ¿no? ¿Sí, Miguel?
Sí, sí.
Ok.
Sí, doctor, sí.
Bueno, vamos a continuar. Y no lo pones en el chat, por favor. Pero cuando lo tengas, no es urgente. Pero para que no se nos quede esto así en el tintero.
Hello, my name is Carina Blomström Lundqvist from the Department of Cardiology, Uppsala University in Sweden. It's my pleasure to present how to prevent sudden cardiac death at the ESC Congress 2020, the digital experience, my disclosures. As we know, there is an inverse relationship between absolute numbers of events and incidents, and a large portion of total sudden cardiac death population burden are from the general population and those with risk profiles for coronary artery disease, but free of events. And the incidence of sudden cardiac death is very low. If we look at the population with risk factors for sudden cardiac death, the incidence of sudden cardiac death is much higher. Risk factors include low left ventricular ejection fraction, presence of heart failure, survived cardiac arrest, and risk markers like post-MI. Based on these risk factors, we have several ICD trials showing a benefit of ICD as compared to controlled treatment for primary prevention and secondary prevention of sudden cardiac death. Now, let's look at other publications and guidelines that are based on these trials. We have several guidelines published. We have the 2015 ESC guidelines for management of patients with ventricular arrhythmias, A couple of years later, the same type of guidelines published by the AHA, ACC, and HRS. Also, the 2016 EC guidelines for treatment of heart failure patients, and a recent update on management of heart failure published 2019, focusing also on sudden cardiac death. Patients with LV dysfunction with or without heart failure, what are the recommendations for primary prevention of sudden cardiac death in this population? ICD therapy is, as you know, recommended for patients with a low ejection fraction and function class 2 to 3, based on 2 large trials, the SCADHEF trial and the MARDI-2 trial, and also meta-analysis including 5 primary prevention trials, including also patients with dilated cardiomyopathy. So the recommendations is a class 1 recommendations for ICD therapy in patients with ischemic etiology and non-ischemic etiology of heart failure. What about patients early after myocardial infarction? Well, we have trials telling us that there is a different scenario. So ICD is not recommended immediately post-MI during the first 40 days. And this is based on the IRIS and DYNAMITE trials published previously, showing that ICD do not change outcomes early after MI, no different between controls and ICD recipients. And this was strongly confirmed by a recent VEST trial, also showing no difference between controls and patients receiving an ICD-West early after post-myocardial infarction in patients with reduced LVEF. What about primary prevention of sudden cardiac death in non-ischemic cardiomyopathy? As you know, the trials, including only patients with dilated cardiomyopathy, did not show a benefit for ICD versus optimal medical therapy. But a meta-analysis, also including the more recent Danish trial, did show that ICD therapy appears to significantly reduce total mortality in selected patients with non-ischemic cardiomyopathy. And several meta-analyses has provided these data. Now, if we look at the Danish trials, including over 1,100 patients, there was no difference, as said, in all-cause mortality. However, for patients less than 59 years, ICD almost halved the mortality. So how did this affect the guidelines published after the Danish trial? The guidelines published by AHA and HRS coming out in 2018 had no difference. They still recommend ICD as a class 1 recommendations with patients in function class 2 to 3 with heart failure and LVEF of 35% or less. But in a recent update from the EEC, update on heart failure treatment 2019, as said, they did not identify any new evidence for patients with coronary artery disease, but they stated that you may consider not to implant an ICD in patients with non-ischemic heart failure, for patients older than 70 years, for patients with function class 3, 4, and for patients with comorbidities. This is also supported by the long-term outcome of implantable cardioverter defibrillator therapy in the SCADHEF trial, recently published this year. They concluded that treatment-related patterns of long-term survival with ICD benefit most evident for ischemic heart failure patients, as shown here, and also for New York Heart Function Class 2 symptoms. What about primary prevented ICD trials? Is left ventricular ejection fraction still valid? And that is related to the increasingly use of the effective of beta blockers, heart failure treatment, revascularization, and also novel treatment introduced like sacubitril and valsartan as in the paradigm heart failure trial. We have a recent publication showing that there is a 44% decline in the rate of sudden cardiac death across the trials. And there's a cumulative incidence of sudden cardiac death at 90 days after randomization was 2.4% versus only 1% in earliest versus most recent trial. So related to the decline in the incidence of sudden cardiac death in these high-risk patients, we can see that the sudden cardiac death rate in the control group from the SCADHEF trial and the Paradigm trial was similar. There is a recent, very interesting publication showing predictors of sudden cardiac death in high-risk patients following myocardial infarction, that left ventricular ejection fraction of 35% alone is a poor discriminator of sudden cardiac death risk. The addition of other risk variables stated here from the model was greatly improved reclassification of sudden cardiac death events. And the observed 2-year incidence of sudden cardiac death increased from 1.9% to 13% in the highest quantile of risk score. So that may identify patients to prevent sudden cardiac death early after acute myocardial infarction, although more trials are needed to prove and show these data are valid. So conclusions can be made. With novel medical and device therapy, the risk of sudden cardiac death in heart failure patients has declined over the past 20 years. More data are needed to better identify high-risk patients and to assess benefit of ICD for overall survival in both coronary artery disease and non-ischemic cardiomyopathy patients on optimized heart failure treatment. Novel predictors of sudden cardiac death in heart failure subgroups, non-ischemic cardiomyopathy patients, and early post-MI patients are, however, yet not validated in randomized trials. Thank you for your attention.
Si tuviste tiempo de copiar la referencia, Miguel.
Sí la alcancé a ver, doctor, pero no la copié. Pero ahorita la busco.
Ok, deja verla. No, está muy cerca. Ahí está, Miguel.
Ya. Sí.
Ok, seguimos.
Sí.
Death increased from 1.9% to 13% in the highest quantile of risk score. So that may
Cardiology Network.
Hello, this is Dr. Taya Glotzer presenting from Hackensack, New Jersey. The title of my presentation is When Do We Need to Anticoagulate in Subclinical AFib? And I'm very pleased to present at ESC 2020, the digital experience. I have nothing to disclose. So what is subclinical atrial fibrillation? It's only detected in patients who have implanted devices that record and store 24/7. The episodes are often brief in duration. The episodes are usually entirely asymptomatic. And what you see here, these terms, silent AFib, subclinical AFib, device-detected AFib, they all are used in the literature interchangeably. What is the incidence of atrial fibrillation in patients with implanted devices? Well, if you take all comers, patients who may have a history of AFib, about 50% of patients with implanted devices have AF on their devices. If you try to exclude patients who may have a history of AFib, may have a history of stroke, or on antiarrhythmic drugs, the incidence is about 30%. Because people thought these arrhythmias were caused by the implanted device, there's been a lot of interest in looking at AFib with screening, taking elderly patients with cardiac risk factors, implanting loop recorders, and again, we see the incidence of device-detected silent AFib is about 30%. And now that patients have these new devices that they wear and they come to us in clinic with episodes of arrhythmia, we really need to learn what duration of AFib requires anticoagulation. What is the clinical significance of these atrial events? Well, first, are they symptomatic? This is 1 month of Holter recordings in patients with PSVT in red and AFib in blue. And we see that patients with PSVT are much more likely to be symptomatic, and patients with AF are much more likely to be asymptomatic. And after ablation, these are all patients who had symptomatic AFib. And we see that prior to ablation, only 20% of the episodes were asymptomatic. But after ablation, 3 months, 6 months, and 12 months, almost 100% of the episodes were asymptomatic. So this is the question we're asking today. What duration of subclinical AFib warrants anticoagulation? Look at these numbers on the left and see what you think, and I will try to answer the question for you today. So this slide shows all the different studies that have been done over the last 15 years, looking at different AF burden measures, 5 minutes, 24 hours, a combination of CHAD score and AF burden, 5.5 hours, 3.8 hours. And it seems that no matter what AF burden measure you study, the hazard ratio for stroke event is at least doubled in a statistically significant way. So no matter what AF burden you have, even 5 minutes, your stroke risk is at least doubled. And we need to determine if anticoagulation is the proper therapy. This is the risk of stroke and embolism in non-anticoagulated patients by AF duration and CHADS VASC score, data obtained in over 20,000 patients from electronic health records and CareLink. And what we see is that if your CHADS VASC score is low, 0 to 1, it doesn't matter. Even if you have 24 hours of AFib, your stroke rate is low. And if your CHADS VASC score is 5, even if you have no AFib, your stroke rate is high. And it seems that somewhere in the CHADS 2 to 4 range, perhaps the duration of AFib does impact the stroke risk. And the next question people wonder is, does this AF detected by devices actually cause the stroke? So these are studies that have looked at the temporal relationship, and it turns out that most of the time, there is no AF detected in the 30 days prior to the stroke, and only rarely is there any AF detected prior to the stroke, begging the question that whether this is a causative factor or perhaps a marker. And perhaps we should look at this updated model of thromboembolic stroke, where there are vascular risk factors that contribute to an abnormal atrial substrate that may cause stroke, and AFib is perhaps a bystander. And subclinical AFib, rather than being a causative factor, where there is a direct cause and effect relationship, perhaps it's just a risk marker that simply identifies individuals at increased vascular risk. So the decision to treat with anticoagulation, we need to assume that the bleeding risk of anticoagulation therapy is less than the stroke risk of AFib if we're going to treat these subclinical AFib episodes. So there are many studies ongoing trying to answer the question what to do with subclinical AFib 6 minutes to 24 hours. This one is going on in the US and Canada. It's called Artesia, taking patients with risk factors, 1 episode of subclinical AFib, and they're being randomized, double-blind, double-dummy, to active aspirin or active apixaban. The same study is going on in Europe. Patients with risk factors, atrial high rate episodes greater than 6 minutes, are being randomized to aspirin or placebo or edoxaban. And then there is the Danish loop study ongoing, taking 6,000 elderly patients with one of the following risk factors, and they're being randomized to loop or standard of care. If AF is detected on the loop, treatment is not mandated, but the patients will be followed to determine if early detection and possibly early treatment will help or hurt patients. So what should you do when you detect device-detected AFib? Always review the stored intracardiac electrogram. Often the digital reports by devices are wrong and it's a false detection. Determine the duration, assess the CHADS-VASc score, and recognize that symptoms do not play a role. There are many published guidelines by the ESC, by ERA. This is the most recent guideline from the US, recommendations for device-detected AFib. It says, in patients with cardiac implanted devices, the presence of recorded atrial episodes should prompt further evaluation to document clinically relevant AFib to guide treatment decisions. And in the text, prospective clinical trials of prophylactic anticoagulation are underway but have not been completed. Those are the studies I just shared with you. And although the increased duration of atrial high rate episodes is associated with increased stroke risk, the threshold duration that warrants anticoagulation is still unclear. So what do? I'm lucky enough to be part of the Artesia trial. So when I see anyone with 6 minutes to 24 hours of AFib, I put them in this study because I don't know the right answer, and I don't think anybody does. Certainly, I think if we see more than 24 hours of AFib with an appropriate CHADS-VASc score, patients should be anticoagulated. But in addition, all of these lifestyle modification things, diabetes, smoking, alcohol intake, obesity, sleep apnea, when we see device-detected AFib little bits, we know that the cardiac health is not going in the right direction, and we should do everything we can to modify these things to decrease left atrial fibrosis, inflammation, and cellular changes that we know lead to atrial fibrillation. So at a minimum, lifestyle modifications must be done when we see device-detected AFib. So in conclusion, stored electrograms must be reviewed to confirm the presence of actual AF. Longer duration monitoring detects more AF. There is more asymptomatic AF than symptomatic AF. Symptoms are irrelevant when making a decision about anticoagulation. Patients with subclinical AF have an increased stroke risk compared to patients without. And the stroke risk is based on a combination of stroke risk factors and AF burden, still yet to be determined. But when subclinical AF is detected, lifestyle modifications must be recommended. I thank you so much for your attention, and it was a pleasure to participate in ESC Digital Experience, but next year I would much rather be there in person. Thank you.
¿Algún comentario? Creo que esta presentación es todas, ¿no? Pero esta es bastante buena. Creo que nos tenemos que quedar con un concepto que también no tenemos mucho, como dice el doctor Leiva, en el radar, que es el high atrial rate, que se identifica en muchas veces cuando interrogamos marcapasos, ¿no? Y que no era un término que se estaba manejando mucho y que se ha estado manejando mucho durante las presentaciones de la Sociedad Europea, ¿no? ¿Algún comentario, Poncho o Ricardo?
Pues sí, doctor, en cuanto a este nuevo término y a esta clasificación de fibrilación atrial subclínica,
Double blind, double dummy.
pues no queda más que decir que recordar que eso pues lo podemos saber nosotros interrogando los marcapasos. Muchas veces llegan pacientes a los cuales o llegan a hospitalizarse con síndrome isquémico vascular y pues llegan ahí, interrogamos el marcapasos, tal vez nos digan, ay, sí, es que por aquí le veo un trazo de arritmia. Entonces, la importancia de decir que te imprima el trazo, tú revisarlo, ver qué otros factores de riesgo tiene, lo que ya veníamos en las guías que vemos en esta diapositiva, las comorbilidades que pueden ser substrato, que pueden ser desencadenantes de la misma y calcular el riesgo de hemorragia. Si nosotros vemos que son varios episodios los que está presentando el paciente, tiene factores de riesgo como un substrato para desarrollar próximamente ya fibrilación auricular permanente o por lo menos ya paroxística, pues entonces nosotros ya empezamos a dar tratamiento anticoagulante. Por ahí menciona el estudio con apixaban 5.2.5. Regularmente pues son pacientes ya seniles los que vemos con dispositivos implantables. Entonces pues sí, estar únicamente al pendiente de este nuevo término y saber a qué se refiere, ¿no? El tiempo de duración, la importancia de la duración.
Sí, perfecto. Creo que este diapositivo es muy importante. Siempre tenemos que tener en mente el tratar de modificar todas nuestras enfermedades cardiovasculares. Sobre todo fibrilación auricular, no digo todas, pero fibrilación auricular siempre tenerlo en cada caso, ¿no? Insuficiencia cardíaca, cardiopatía isquémica, fibrilación auricular, sí, valvulopatías, estenosis aórtica, etcétera. Ok. Bueno, muy bien, jóvenes, pues si quieren aquí le dejamos y nos vemos al rato para pasar visita.
Sí, doctor.
Sale, nos vemos 8:30. Gracias. Miguel, tendrás te encargo que nos subas en el correo o en el chat el artículo que vimos, ¿no? Para tener ahí lo del score de riesgo de muerte súbita, Miguel, ¿no?
Sí, ahorita lo descargo.
Órale. Gracias, bye.
Bien.